A 24-year-old female presented with chronic headaches and visual loss. I'm showing you T1 sagittal, T1 coronal, and T2 coronal brain and orbits MRI scans. Describe the findings.
All right, let's take a look. The brain MRI demonstrates marked expansion of the sphenoid sinus, which is filled with abnormal soft tissue signal rather than normal air. The sinus contents show mild, uniform hyperintensity on both the T1-weighted and T2-weighted sequences. This T1 hyperintensity is characteristic of proteinaceous or highly viscous fluid. The bony walls of the sphenoid sinus appear smooth, thinned, and expanded, but are completely intact with no evidence of osteolysis or frank bony destruction. The coronal T2 image confirms superior displacement and compression of the optic nerves and chiasm, explaining the clinical history of visual impairment.
I am showing you magnified and annotated sagittal and coronal MRI scans of the sphenoid region. What is the diagnosis, and what are the key differentials for a sphenoid sinus lesion?
The diagnosis is a sphenoid sinus mucocele, causing optic pathway compression. The differential diagnosis includes a sphenoid sinus carcinoma, a pituitary macroadenoma with sphenoid extension, a chordoma, and a sphenoid sinus fungus ball. A sphenoid carcinoma would present with aggressive osteolytic bone destruction and invasion of adjacent structures, rather than smooth remodeling. A pituitary macroadenoma would center on the sella turcica, expand the sella, and show uniform solid enhancement.
Explain the pathophysiology, predisposing causes, and common locations of mucoceles.
A mucocele develops secondary to chronic obstruction of the sinus ostium, commonly due to chronic rhinosinusitis, nasal polyps, trauma, or prior sinus surgery. Following osteal obstruction, the sinus continues to secrete mucus, which accumulates and progressively increases intrasinus pressure. This chronic pressure acts as a slow-growing mass, resulting in smooth remodeling, thinning, and expansion of the sinus bony walls. Mucoceles occur most commonly in the frontal sinus, accounting for 60% of cases, followed by the ethmoid sinus. Sphenoid sinus mucoceles are rare, accounting for less than 10% of all paranasal sinus mucoceles.
What are the clinical presentations of sphenoid mucoceles, and how does MRI signal vary depending on fluid content?
Due to their deep location, sphenoid mucoceles present late with deep-seated retroorbital headaches and visual disturbances due to compression of the adjacent optic nerves or chiasm. They can also cause cranial nerve palsies of the third, fourth, or sixth nerves by compressing the cavernous sinus laterally. The MRI signal intensity varies dramatically based on protein concentration and hydration state. Early, watery mucoceles are low on T1 and high on T2, whereas protein-rich or dehydrated chronic mucoceles are T1 hyperintense and can be T2 hypointense, sometimes mimicking a solid mass.
What are the roles of CT and MRI in assessment, and what is the treatment for this patient?
CT is the optimal modality for demonstrating bony expansion, osteal obstruction, and confirming the complete absence of aggressive cortical erosion. MRI is essential for mapping the relation to the optic pathways and carotid arteries and diagnosing lateral cavernous sinus displacement. The definitive treatment is surgical, involving endoscopic sinus surgery with transsphenoidal marsupialization and decompression of the sinus. As a radiologist, I would recommend immediate ENT referral for decompression to prevent permanent optic nerve atrophy and irreversible visual loss.